very warm welcome to everyone joining our virtual care webinar today. It gives us great pleasure to bring you real innovation from the front line, where West Moreton Health, Illawarra Shoalhaven Local Health District, and Southern NSW Local Health District will share with you their insights on how virtual models of care for patients in the home can create capacity, improve access, and improve lives for their community. My name is Shannon Fernando, and I'm the Regional Director for Philips' Population Health Business Unit. I will be your chairperson for this event. To get things started, I thought it would be helpful to contextualize the healthcare challenges we face today. The global healthcare challenges related to insufficient access to care, escalating healthcare costs, and a significant shortage of clinical resources is not new to you all. Added to this, the COVID-19 crisis is set to add to this challenge by creating unprecedented demand on your hospital resources and your clinical resources. Clearly, doing things the way we always have is just not going to be an option going forward. Amidst this crisis, however, we are faced with an exciting opportunity that digital enables in terms of changing the traditional models of healthcare delivery. There's a new generation of tech-savvy patients and health consumers who want to use technology in a different way. They're exposed to their banks and their retail brands, and they want to experience healthcare the same way these other industries deliver services to them. Added to that, doctors and clinicians in general, they want to adopt technology as well. They increasingly expect to work in this digitally enabled environments where scrum teams, interdisciplinary teams, shared decision-making are things they just have to do to optimize the care delivery and to improve outcomes for their patients. This creates an exciting opportunity for us to shift the traditional paradigm of healthcare delivery. This is all enabled, in our opinion, by the concept of the virtual hospital. In this new solution space, the traditional boundaries of clinician to patient ratios are redefined. It's a one-to-many relationship rather than a one-to-one relationship. In this model, a highly trained group of healthcare providers are able to care for hundreds, if not thousands of patients in the community. They can only do this with the power of technology that allows them to be proactive and through data-driven insight, focus on really what matters at that point in time. Today's webinar will bring you this innovation from 3 hospital and health systems. You will learn about why these programs were adopted, how they operate, and what is needed to be successful, how to rapidly implement these solutions, some of the COVID-19 protocols being developed, and how this enables scale across your health system. In terms of the sequence of events, initially we will have our 3 health system partners share with you their journey in setting up their virtual care solutions, followed by an interactive 20 to 30-minute panel discussion. If you have any questions throughout the presentations, please click the questions box below. It would be great to have your name and organization as part of your question. If you choose to, you do have an option to be anonymous as well. It gives me great pleasure to introduce you to Melinda Parcell, Executive Director, Community and Rural Health Services from West Moreton Health, Shannon Wallis, Nurse Unit Manager, MeCare Services, West Moreton Health. West Moreton Health has been a long-term partner of Philips, now running their MeCare program for just over 4 years. It is going to be a fantastic opportunity for us all to learn about this innovative journey that they've been on and how they're scaling this program into the future.
Thanks, Shahan. Quite rightly, West Moreton's been in partnership for Philips for just over 4 years now, where we've cared for nearly 400 patients on the MeCare system. We first went down the track of getting a virtual health system because we are and have continued to be the fastest growing HHS in Queensland with the fastest relative growth. And so we were looking for a system not only for today, but for tomorrow's population as well. So we're wanting a system that would help us flatten that curve and manage that growth, particularly for the dearth of patients with long-term conditions that we have in West Moreton. West Moreton sits at the back of Brisbane by about 35 minutes. It's got very low CFA index, so we've got lots of people with disadvantage that live in this area, and long-term conditions are our key DRGs of respiratory with COPD, heart failure, cardiology and diabetes. And the program of MeCare has really helped us to change the way we care for these patients and our patients, and it's certainly changed the way we view long-term conditions. But more recently, we've had the opportunity to flip over from looking at long-term conditions and look at this system to adapt it to a COVID response, and we'll talk about that in a little bit. But I did just want to highlight a few things about MeCare. We're really pleased that what MeCare has delivered for us is we have seen a significant reduction in people who've presented to our emergency department, and we've got a very busy emergency department with more than 250 presentations per day. We've been tracking these patients, some of them have been on the program since the beginning, so for nearly 4 years, and we've seen a significant reduction in their presentations, their admission rates to hospitals, and also the cost of care. And this partnership that we've had has really been fantastic, and it's been successful because we've recognised that West Moreton can't do it all. We provide great clinical care and the clinical expertise, but what Philips has done for us with MeCare is provide the data analytics as well as those technology platforms. So that's what we've done from MeCare. So off the back of that, we've got staff who are very comfortable working in the virtual space, and we've got a multidisciplinary team that does that. And Shannon will be on shortly, who's our nurse unit manager, to talk about some of the details of caring for patients virtually.
I was just going to talk a little bit about the MeCare model, because obviously it's a hybrid virtual care model that supports patients during their entire healthcare journey and really assists with coordinating care delivery in the patient's home. So the technology that we use from our partners at Philips really aims to facilitate that integrated care across primary, community and the hospital interfaces, and it promotes that information sharing, which we all know leads to more effective management and integrated care of the patient. And MeCare particularly has found benefits over the last 4 years with the health change and behaviour change that we complete with our patients. Using that framework, really, we have found delivers patient-centred care, and we really focus on like health literacy, shared decision-making and self-management, and behaviour change that really increases adherence to lifestyle recommendations and evidence-based practice. So the components of the program that I think we have found that have led to the better patient outcomes are really around that data aggregation and risk-based stratification. We work with our partners at Philips to use the analytics and machine learning to really identify our high needs chronic disease patients. And we use that data then to really target and focus inviting those patients to come on board the program and work with them in regards to their multiple chronic diseases. Also the clinical and operating reporting that we're able to use, clinicians are able to use that to really review regularly, and it enables our workforce to really be agile and make operational changes to improve patient outcomes in real time. And of course, it's our care coordination supported by the remote patient monitoring and the telehealth, and utilising really patient-centristic, goal-driven coaching. We have a multidisciplinary team in MeCare, but each of our staff really is interdisciplinary, and they flex in and out of that coaching role to really instill behaviour change long term. When we look back at our data over the last 4 years, lots of it indicates that it often takes 9 months to 10 months for someone to change their behaviour. So, you know, it's often not a quick fix, and seeing that change over time has brought great benefits. And of course, the software that we use with Philips enables us to really connect and support clinicians across multiple interfaces. So I think that they're some of our main benefits that we've brought for our patients.
Some other key benefits that we're just starting to explore now, and I think will be a driver for healthcare in the future, are also the patient-reported experience and the patient-reported outcomes. And the MeCare system, the MeCare program, have been measuring PREMs and PROMs from the beginning. So that's given us a great baseline of work and really helps us into the future to tailor our healthcare to what patients actually need to match their experience and to match their outcomes. But in this rapid stand-up of COVID, working with Philips, we were able to use our platforms that we've invested in to pick up the COVID patients in 2 ways. So we can look after patients with COVID with Lighttouch, so that's with full virtual monitoring back to our central hub, but also in a Lighttouch way, where patients can use their own device to log their symptoms. And fortunately for us in West Moreton, we just saw around 40 patients that were positive for COVID, and most of those had mild symptoms. They were able to rapidly stand up a program within a week, within 7 days, to manage all of those patients quite sufficiently in the community. And it was a great opportunity for us to expand our wings. And so now what we're looking for is where else can we use it. But Shannon, it'd really be great if you could just outline some of the clinical nuances between our MeCare and High-Touch HIF, which is the full virtual monitoring, and what we've done from a Lighttouch COVID perspective.
So with our COVID virtual care monitoring, as Melinda has said, we really wanted to leverage off the infrastructure and the workforce capability that we've developed with our partners at Philips over the last 4 years. And we were able to stand these models up quite quickly. You can see that in our first lot of COVID patients that were transitioned to virtual care, that was done on the 1st of April this year. And we were able to really monitor around 22 patients across the HHS. Depending on their acuity, we were able to measure either temperature, blood pressure, oxygen levels, and be able to provide them with some health surveys to really assist their healthcare providers to monitor their disease progression. And the ECP platform really has provided us with two functions. And those two things are that it really enabled our patients to feel a level of support, and they were able to, even though only having mild symptoms, the clinical staff were watching over them and monitoring them while they were at home. And it also really provided our clinicians, and particularly our infectious diseases physicians, with some comfort knowing that they're able to monitor the patients and communicate with the patients via the virtual platform, via teleconferencing. So, you know, our patients, it provided them with this reassurance, and the feedback from the patients has been very positive. And when comparing these virtual models with traditional models, you know, they really believed that it's provided them with more choice and autonomy over their healthcare plans.
Because, you know, the COVID-19 is a novel coronavirus, we were quite uncertain in the ways that to manage these patients, but also there was a high level of anxiety in the community. And what the Lighttouch program was able to do, it was able to give comfort to the patients in the community, knowing that they could upload their data each day, take their surveys, and that was being monitored and responded to. They could reach out to us when they wanted to, but likewise we could reach out to them. And the second thing it's done, it's brought a huge level of comfort to those our physicians who are caring for them. So our ID physicians have never dealt with COVID before, and so what it was able to do was for them to confidently care for these patients in a community setting rather than overloading our hospitals and admitting everybody. So I think they're the two real benefits: comfort for the patients and comfort for our staff who are looking after them in this new way. But the future, now that we know that we have this Lighttouch, is looking at what are the other opportunities to apply this system to other groups. And we certainly have identified quite a number we want to branch into, particularly other highly motivated groups like women suffering from gestational diabetes. It's short term. All women are very interested in having a healthy baby. And so this Lighttouch program, where patients are really self-motivated to enter their OBS each day and follow a care path with the monitoring system that sits behind, which provides comfort to the clinicians, I think that that's going to be our next steps. Just on the 4 years that we've had MeCare for, what we've been also working in the background is how do we provide that level of support to our other HHSs, either across Queensland or across the nation, that we can pass on our learnings, because it has been a new way of working for us. And we've got evidence now that our patients do think that virtual healthcare is as good as traditional methods, but there are nuances to working in a multidisciplinary way with virtual healthcare. So we'd like to share those learnings. So we've been working on developing up a virtual care capability framework that we're hoping to share with other partners, so that we have a community of practice established for virtual healthcare, other virtual healthcare providers, so we can learn and share, because this is the future. And finally, I think it is the foresight and the boldness that our HHS board and chief executive had 4 years ago to invest in a new model of care and in MeCare, and the experience that we've had along the way, where we've now brought up a whole range of multidisciplinary team that are capable of working virtually, is the reason that we're able to then turn this system around to standing up within 5 to 7 days and have a whole COVID response So our community has been covered from a COVID perspective very quickly, and everybody's been very comfortable with that, both the community feedback and the feedback from our clinicians. It hasn't happened overnight, but it's been an investment that has paid off for our long-term conditions and is now paying off for COVID. And we're looking forward to how else we can apply this new system. Thank you.
Melinda and Shannon, thank you so much for sharing with all of us here your 4-year journey in implementing this capability that you've built. Certainly your ability to react to COVID, as you said, in such a short period of time has only been enabled because of this long-term vision and investment of your HHS.
Thank you.
Thank you.
For our second speakers, please welcome Lou Fox, General Manager, Ambulatory and Integrated Care from Southern New South Wales LHD, and Netty Swinburne Mepham, Program Manager of Integrated Care, Southern New South Wales LHD. Southern New South Wales LHD and Illawarra LHD have been on an accelerated program to implement their virtual care solution in response to not only their needs in the community, but also to manage the COVID-19 crisis that is facing us all.
Thanks, Shahan. Thank you for the opportunity to talk about Southern New South Wales today. Southern New South Wales is a regional local health district in New South Wales that covers the southeastern portion of the state. We're a small LHD with a number of small hospitals and 2 larger hospitals in our district. One of the things that's really unique about Southern New South Wales is that we're one of the few districts in New South Wales that doesn't have a tertiary hospital. So it really means that we're dependent on our relationships with our partners in the ACT and in metropolitan Sydney to deliver specialist care. The population in Southern New South Wales is around about 200,000 community members who are spread quite broadly across very small community centres. We have around 9,000 Aboriginal and Torres Strait Islander community members, and we have a very high prevalence of chronic disease and community and social disadvantage across the district. Southern New South Wales has a geographically dispersed workforce. We have very high dependence on locum medical officers, and subsequently what that means is that our ability to scale out programs of care is really dependent on our capacity to recruit locums. We have small clinical teams who work in a generalist model of care, and that means they work in our hospitals, community health centres and outpatient care settings.
So our virtual care program started off as Connecting Care Plus. We have a lot of drivers, as Lou has mentioned, about our diverse geographical location, our ageing and vulnerable population, as well as clinicians who work in a generalist environment. We looked at connecting care as a way to reduce preventable hospital presentations and admissions, and looking at the rising risk and those with chronic disease management. So the benefits of a virtual community centre are the opportunities that this has for our staff as well as our patients. Our staff can work in a centralised location, even though they're dispersed. Our patients can access care, so it's equitable, no matter where they live and what services they use. We look at our VMOs in our hospitals who also work as GPs in our communities. Having a virtual care centre means that we can share the knowledge and also share the technology from our LHD into our primary care providers. We can align some of our core functions in the LHD as well into this centralised hub. We have opportunities for our generalists to become specialists in the virtual care centre. We're creating dedicated pathways for patient care, and centralising this service means that we can instigate some centralised governance, which means that care for our patients can be escalated and followed through into acute hospitals as and when needed. Southern's in a unique situation that we are bordering the ACT. At the moment, many patients have to cross the border for those tertiary services. With this model, with a virtual care model, where we incorporate across the LHDs into Illawarra Shoalhaven, it means that our patients don't have to travel as far and they have access to specialists from home or from their GP or from their community care centre.
Southern New South Wales had identified an opportunity to use the work that we had completed in the virtual care centre and to repurpose that to manage COVID patients in the community. For us, that was a really important opportunity, knowing that we have a small number of staff across the district and we would need to increase our capacity within a very short period of time. One of the opportunities for us was in looking at the model of care and the clinical expertise that we had identified for our staff working in our Connecting Care Plus program, and how could we leverage that for the COVID context. So there were some significant barriers for us in terms of having to do this work in a very short period of time. I think the partnership that we have with Illawarra and with Phillips and with the Primary Health Network meant that we had confidence in the decisions that we had made as part of our Connecting Care Plus model, and we could quite readily transfer this across to COVID. So we had done some work around our capacity and demand management in relation to COVID, had identified an opportunity to share some medical governance, which includes a different level of expertise to what we would see purely in a chronic disease space. Illawarra and Southern both have access to medical specialists, and all of those medical specialists are able to support our COVID community patient management models. So this includes working with people in infectious diseases and respiratory settings, as well as leveraging a number of nursing and allied health staff. So I think one of the opportunities for Southern was in looking at our internal skill set rather than recruiting a new clinical team, and identifying people with significant clinical expertise to bring into our virtual care team in a matter of days. In Southern, we have been fortunate enough to be able to access a nurse practitioner in chronic disease as well as a respiratory physician to put in as full-time members of our virtual care team. We've developed a clinical model of care that delineates between patients who need high level of monitoring using the Philips home-based kit, or a lower level of monitoring, which we had identified the opportunity to use the web portal and to encourage patients to upload their own observations if they were able to do that. Within our home monitoring proposed model, what we had identified was ready access to a number of our allied health staff, including occupational therapists, dietitians, physiotherapists, speech pathologists, and nursing staff, who could work very comfortably from a number of locations across the district in our virtual care team to complete daily monitoring with patients in their homes. We did identify that patients who were on the high care pathway required direct access to a clinician who had a higher level of clinical expertise. And our preferred model for that staffing system is to have registered nurses, respiratory physiotherapists, with a number of specialist nurses and an escalation pathway to our doctors. So we have identified a coordinator for our virtual care COVID service who works 7 days a week. That allows us to have direct escalation pathways back to our hospital facilities so that we can organise a planned admission or a planned presentation for those patients who've had a virtual review but who also need a hands-on physical assessment. That gives us great capacity to manage patients closest to their home without requiring them to travel 2 or 3 hours to a tertiary hospital, because we have direct access to a medical escalation pathway and a doctor-to-doctor handover from virtual care back into the hospital.
Netty and Lou, thank you very much for sharing with us your journey on implementing your virtual care solution. I think what's really unique about what you're doing that I certainly have seen is that you have a partnership. This is a partnership with 2 LHDs coming to deliver one solution, one service, 2 LHDs is what your vision is delivering. It's great to see the strong clinical governance model that you've put into place that of course is aligned with New South Wales Health in terms of being able to make sure we're going to be delivering strong clinical outcomes. Thank you again for your time today.
Thanks for having us, Shahan. Pleasure.
Thanks, Shahan. Thank you.
For our final presenter, please welcome Franco Fatty, who is the stream leader for integrated chronic disease management from Illawarra Shoalhaven LHD. Franco is going to share with us all her accelerated journey to implementing this program and the key success factors in getting such a program off the ground in record time.
Thank you so much, Shihan, and the rest of the team. It's a great opportunity to be able to provide our perspective of implementing and working in a virtual care model in our district, which is relatively new for us, as it may be for many other localities. Just, I guess, a little bit about the Illawarra Shoalhaven Local Health District. For those of you across Australia, the Illawarra Shoalhaven Local Health District is south of Sydney. We're a beautiful part of the coastline. We cover about 250 kilometres of coastline and comprise 4 local government areas. We've got 8 hospitals and more than 55 community health services. Our population is a little over 400,000 people. We have a significant proportion of people who are aged over 65. We have a population of Aboriginal and Torres Strait Islander people of 3.4%, and about 19% of our people were born overseas. Our population, I guess, is made up of people who have lived in the area for a long time, and our history is one of heavy industry. So we do have people who have the legacy of having worked in those kinds of jobs in terms of chronic disease amongst our population. We also have a lot of retirees who come to our area, particularly in the Shoalhaven, where they've lived all their life in Sydney and they come down to their holiday home but are very disconnected from the community to a degree. So their access to health services is relatively immature to a degree. We also have significant pockets of social disadvantage despite our beautiful area. And this is reflected in poor food security, poor health literacy. We also have people who are quite significant unemployment rates amongst young people and older people as well. So we have a mix of high-end mobile and active people in the community along with significant pockets of disadvantage. So that gives you a bit of a feel for the diversity of the people who come through our health system. In terms of why we decided or felt that it was time to move on to models of care that are more available, I guess, and more accessible to our whole population, we acknowledge that there are many people in the community who actually refer to, and it was reflected in our health service development planning of the last couple of years, who feel that we are laggards in terms of technology and the way that we interface with our community from a health perspective. That people were actually quite surprised that we're still sending letters to them and only calling them on the telephone. There's a high expectation that a modern health agency actually utilises technology and is at the forefront of technology, but despite those impressions, we're actually not very good at that at a local level. We're conscious of that. And we had been, as Lou Fox and her team in Southern would have presented, this evolution was part of planning that we'd already commenced with the Southern Local Health District, with our primary health network and with Philips, in looking at a model or an expanded model with Philips to provide chronic disease management to a wider range of people. The advantage of that for us is that it allows us to scale to a wider and larger group of people in our community, because whilst people value face-to-face, we just do not have the workforce or the capacity, and our region is far too large to be able to provide that high intensity and quality care at a face-to-face level to everybody. If we start to incorporate elements of virtual care, so where we're able to monitor remotely and interface face-to-face or via video conference or a telephone more frequently, we're able to scale and provide more care to more people in more timely fashion. So that was one of our key considerations. We also, as described before, we're leveraging key enablers like shared governance between our respective organisations, particularly our primary health network. We're also working on agreed pathways of care, which we utilise and showcase through our Health Pathways community, and also the work we've been doing in another enabler, which is secure transfer of information. So this model is actually supporting some of the other work that we're doing. It's not a one-off little exercise that we're working on. It's part of a wider range of strategies that we've been working on for a while. We're expecting, as I mentioned earlier, that this model will allow us to be much more flexible and provide less restrictive care for our patients. So we've got various modalities that we can offer them. It'll also provide more safety, a sense of security for people in terms of being able to be monitored remotely, as well as seeing the healthcare clinician face to face, and also provide a greater opportunity for patients to be more involved in their care, because what we've found is when people do understand what the monitoring requires, or biometric measures that might be taken of them and by them, they start to understand a little bit more about what the issues are that start to alert them to some form of deterioration. So patient activation for individual people is something that we see is likely to be a huge benefit in this space. And I guess from a broader system perspective, it allows us to enhance our efficiencies. So again, it's about complementary care, not one system for all people. It's around looking at various modalities, and certainly this COVID experience has propelled us into the future and allowed us to move in this space so much more quickly than we usually plan. It also will facilitate much more shared care, we believe, and reduce duplication. And duplication, as we're all aware, is a major cost factor in our system, where resulting from poor transfer of communication and information and transfer of care, as well as many repeated measurements taken. And if we're able to share that information securely and taken once, it will absolutely improve efficiencies that way. Those efficiencies and that time that we're able to, gain in having a much more comprehensive and secure modality supporting the work that we do will allow us to redirect some of our care into the future to the rising risk populations. And this is an area of work that every single health district across the world struggles with, and that is understanding what that looks like. And we've spoken about this right from the beginning, that by freeing up some of the work that is required in managing those most complex and chronic people, that we're able to actually think about how we might start to address the rising risk issues in our populations. And of course, it also provides us with greater safety for our staff, and this particularly resonates in terms of COVID, where we're able to monitor people without necessarily a risk of any kinds of infection. However, implementing new models of working doesn't come without its challenges, and I suppose particularly when we're fast tracking the implementation of a monitoring process for people who are COVID positive, we've had to compress our planning timeframes, which just doesn't sit comfortably many times with health planners, and particularly in clinical settings. But one of the factors that has enabled us is ensuring that common vision that's helped us and assisted us to meet that challenge. Managing expectations is also a key factor that I've noticed in working in this space, that when you are working quickly, people, yes, they get an understanding and a feel for what we're trying to do, but they may go off and think about or have their own ideas about how that might look, or where they think it's going. So that's a challenge that needs to be monitored. And I guess the other thing is that a challenge is to make sure that whatever we put in place is not self-limiting, in that we do want to make this a sustainable and ongoing process, not just a short-term solution or in a solution that's situated in one small area. We need to ensure that we're thinking ahead as well. For our COVID patients, we believe that our process will allow us to have much more enhanced safety and standardised escalation processes for people recovering at home. We believe that it will allow us, should our numbers increase, to really be able to monitor more people at home, and therefore limit the demand on our inpatient facilities, which, as we're all aware, has caused huge concerns overseas. We also feel that this is a great opportunity to provide shared care with GPs. One of our key factors that we're embedding in our model of care is the liaison and discussion with general practice in managing people in the community, and having real conversations with GPs about their patients who may be COVID positive. We think that that then will enhance our linkages and integration between acute, community and general practice. And in fact, our population health services, because population health sometimes sits outside our systems, the public health units, and is not necessarily, just speaking from our perspective, as integrated into the clinical systems that districts manage. So this has been an interesting exercise to go through in terms of blending the population approaches with our clinical provision. The mobilisation to implement this model quickly has engaged a wider range of clinicians because there's a lot of curiosity and interest in this space. Also, going back to the patient, reducing anxiety for patients who are COVID positive, knowing that there is someone monitoring them or they've got that capability, if they are deteriorating, escalate quickly. And of course, reducing, as I mentioned before, the risk of infection by reducing face-to-face interactions. For my last slide, I just want to highlight 6 key elements that, from my perspective, assist and enable an accelerated implementation in projects like this one, but also broader projects that are complex and require a lot of support and engagement of clinicians across the care spectrum. One of the things that I think has really enabled the very rapid implementation of this new model of care and the virtual model of care is that it's really important to have the patient as our focus and looking at what would support or what would help to support a patient who's COVID positive in the community with greater security and assurance. Critical to our rapid deployment is having partners with a shared vision. And we had, as mentioned before, we had started working on a model earlier on, and that enabled us to actually consolidate our thinking around COVID for this particular exercise. Managing expectations, as I've previously touched on, is critical. Accepting that the program will evolve and change, and this doesn't always sit well with a lot of people. People often need security and they need to be sure about where they're going and what the next steps are, and that's not easy to do when you have a rapid implementation. So we have to appreciate that there's going to be some fluidity. It's like, you know, you need to be stable on a wobble board. That's what it feels like in this space. We need to feel comfortable that, yeah, we're okay, but it is going to be a bit wobbly. We just need to move forward with the right amount of safety in the background. And that comes to the need to foster a real culture of trust, to ensure that you're working with people and have relationships with people that allow you to build on that trust and, I guess, leverage it when you need to. And that's fundamental, I feel, to a lot of deployment of new initiatives, particularly in this space. But I think it's, from my experience, critical in all strategic planning and clinical model implementation. As I mentioned, accepting that planning will not be linear. Another, I guess, analogy for me in this space is there's lots of balls in the air. You've just got to make sure you don't drop the glass ball. Remaining agile for varying needs, because, you know, you get curveballs all the time, and just being receptive to that and not being too stressed or anxious about that this is the space that we're working in and we need to be agile and meeting various needs. Critical, of course, is also executive sponsorship and strong clinical leadership as well. And we've benefited from that in this project right from the start. Our chief executives across the 2 LHDs, as well as our executive director who's sponsoring the project here in Illawarra Shoalhaven, has really been extraordinarily supportive and driven to ensure that this is implemented as swiftly as possible. And that has been a real benefit to this project, which is often mentioned in other project implementation anyway, but critical for a rapid deployment. And engaging with physicians as well. And I suppose I'd like to bring in the fact that we've leveraged those good relationships with our local physicians to be able to develop this model and ensure that there's medical governance and safety across it. And I know that for Southern Local Health District, that's the same. And it's really about working with those people who you've engaged with throughout the year on other issues, to be able to have those frank and open conversations about the development and deployment of a new model. For me, what's critical in this space is that we always had strategy in our sites, in our long-term sites, in terms of our strategy for integrated care. We never lost sight of the fact that this was an example of how we can foster the concept and the necessity to continue to work to better integrate care across the continuum. And that was a key factor that allowed us to move quickly as well, because the alignment across general practice, subacute and community care, and the acute setting was always part of the discussion and part of how we wanted to ensure that the model developed. And I guess we all need to work at the top of our license, and that's really important in terms of being agile as well. They're just some of the summary reflections that I had in working in this space, and I hope that's helped in some way to get your minds thinking about how a rapid deployment or a COVID monitoring process might work in your district. Thank you for your time.
Thank you, Franca, for sharing with us your innovative journey in implementing this program. No doubt this was highly insightful to everyone on this call in terms of the key success factors in implementing such a program.
Thank you.
Thank you, everyone, for listening in. That was the pre-recorded part of our webinar, and I hope that was certainly insightful to you all in terms of the opportunity that virtual healthcare brings. I'd now like to open up the floor to a whole series of questions that have come through, and we'll try and get through as many of those questions as we can. The first one here is, how do you manage patient expectations of immediate response to what is 24/7 monitoring? I think that would be a great question to yourself, Shannon, given that you're very much running a program now for quite some time.
Yeah, sure. Thanks, Shihan. I think it's making sure that the patients, when they first come on board the program, we have a consent form that the patients are required to sign, and they have to understand that the clinical governance of their care still sits with their GP, and we're not replacing any of the current emergency services. We're not an acute care monitoring service. So patients understand that when they first come on board the program, and understand that if they start to deteriorate or feel unwell, then they should still ring the ambulance and present to an ED department. We're very much about supporting them for long-term management, and in the event that they do start to feel unwell and it's quite early in that process, we can support them in managing that and getting help in the primary care space. But we're certainly not an acute care monitoring service, and we make that very clear with our patients right from the beginning.
Thank you for answering that question, Shannon. The other one is from an anonymous person, and it is, the question is, can this model be adapted to implement into residential aged care facilities? I think that's a great question, in fact, for all the different LHDs. So maybe I'll start with Southern on that one. Netty or Lou, would you have some insight regarding that question?
It's Lou. Yeah, I'm happy to answer that one. We've had some early planning internally around the capacity to provide that support for residential aged care. It's certainly very possible around the Lighttouch model, given that the nursing homes have clinical staff available to upload the patient's observations and the parameters. We can use the Philips system to identify any potential deterioration and work in partnership with the nursing home. So it is something that is very, very possible, and I think using the video call functionality also strengthens our ability to assess the patients virtually across our geographical region in Southern.
Thank you, Lou. Franca, from yourself, what are your thoughts regarding Illawarra?
Yeah, we've had similar preliminary discussions with our aged care stream, and exactly the same issues have come forward around the Lighttouch being a really great option to be able to explore with residential aged care facilities. So it is an area that we're keen to move on in a lot more detail going forward.
Thank you. And of course, Melinda, you did talk in your presentation that you're already looking into multiple different areas of scale up of your program. Can you share a little bit more on your thoughts regarding that?
In relation to aged care facilities, we've had quite a number of patients that have been residential aged care facilities that we've provided care to. We have expanded our MeCare, which is normally for patients with long-term conditions, but we now are using this same system for hospital and the home type patients, and of course that's open to residential aged care facilities as they come in, fully monitored beds. But for the Lighttouch ECP web, we are looking now at women with gestational diabetes to come onto that program, because they're a highly motivated group. There's an end date for them. We know that they're all young women, so they love to work in the virtual space. And, if they've often got other smaller children, it saves the whole travel and having to organise childcare, etc. So we're working very quickly to get those workflows up and running so that we can implement that this year.
Thank you, Melinda. The next question I have is actually it's a good one. It's something that I think talks a lot to some of the challenges we do have in our health system, and it talks about is there a potential for patients to be monitored by the GPs in the community? And with a system like this, would hospital doctors trust, in the monitoring that would happen on discharge, and thereby contributing to patients increasingly monitored closer to home? I'm seeing that question very much about, how does that integration and interface with GPs happen? Melinda or Shannon, what is your view in your experience in terms of how you've been setting up programs today?
Shannon, I think you can end off this answer, but I know that we've got a very committed cohort of GPs that are very keen to be involved in a Lighttouch program to look at heart failure titration medication, that they want to be confident by having a system that can, patients will be able to be monitored on, to give them that confidence to get their medications right. Shannon, did you want to expand on that at all?
Yeah. I absolutely think that this type of virtual care could be used in the primary care space. And in fact, in MeCare, our collaboration with the GPs and the work that we do around GP case conferencing, because obviously it's a patient-centric model that we want to put the patient at the centre, and the integrated care across the primary GP service and the hospital interfaces is really important for the patients to understand their care journey and what their management plans are and how to move forward. So I think this type of model would be really convenient, firstly for the GPs, because the patient brings the device to the GP practice, and so GPs aren't having to log into multiple software systems. So it's user friendly, it's patient driven, so that's another great advantage. So I definitely think it could be applicable in the primary care space.
Thank you. And of course, switching to Southern New South Wales LHD and Illawarra Shoalhaven LHD, I know that the PHN has been very engaged with you. Is that something you can expand on? Maybe Lou, you can start, and we'll try and get some feedback.
Yeah, look, I think it's really important to note that our initial proposal around the Philips platform is actually a three-way partnership with the Primary Health Network. We recognised very early on in the piece that we can't do this sort of support without GPs. And so whilst we're still progressing with our Connecting Care Plus model, it really is about a shared health service, regardless of the care setting, working very, very closely with our general practitioners. I think we've had some really good work happening so far in the development of our COVID patient monitoring, which we have been doing in Southern with our general practitioner liaison officers. So we jointly employ GPLOs in partnership with the Primary Health Network to make sure that the model of care really does include very early conversations with the GP. We know that there are pre-existing health conditions that the GP is the one who's managing. And so that needs to form part of that package of care that a patient may be receiving support for in the community. Within the COVID context, I think it's really important to note that this short-term support is really for the management of COVID, not taking over the GP's usual care. So it's really important that we work in partnership and have that clear ongoing communication with the patient's general practitioner.
Thank you for sharing. And I know Southern and Illawarra are doing this together. So Franco, I'm just wondering, is there anything more you want to add to that from what you've seen?
Supporting the comments of both West Moreton and Southern, that I guess this is a reflection from my perspective there. This COVID, I guess, crisis that we're all in has actually facilitated discussions with our primary care partners, as it has in a whole range of other areas with other partners. I think one of the key things that we need to always remember is that this is a fluid space, as I mentioned in one of my slides, is that it's not going to be perfect, and it's not necessarily going to suit every single GP or any of our clinicians, but it allows us a point of conversation, a point of engagement, and a point where we can have discussions around how do we better manage shared care in these types of spaces. So I think it's a great facilitator, to be quite honest.
Thank you, Franco, for sharing your opinion as well. I've got another question. It's a good question. It could be a bit political as well. So let me read it out. Can the presenters discuss some of their experiences in the dealings with the health bureaucracy when implementing the virtual care. So I guess some of the challenges in terms of getting these programs through the health system. Did you want to, since you're on screen here, Franca, did you want to kick off with that one first, and then we'll see what the others have to say?
I think the key factor for us was really executive sponsorship and leadership, and wanting to look at ways to make this happen quickly. And I think you find shortcuts, or not that they're necessarily inferior processes, but you actually cut your way through the labyrinth, I suppose. I think the other thing is being really very clear about your purpose helps in that, and working at the top of your scope. So knowing what decisions you have delegations to make. These are the key factors from my perspective.
A perspective from Southern on that?
I think similar to what we've said already, we were in a very fortunate position where we had a very well-established partnership across the region, including with the Primary Health Network, and that really put us in a good position to make very quick decisions and escalate a piece of work that usually would take us, let's be honest, a good 12 months. Given that there is a very significant immediate demand that we had to meet, that's allowed us to make decisions. And I think the understanding is that we will refine the model as we go, because we are still learning. It isn't something that's going to be perfect, and we're very open to feedback, and we want to work with our partners and get it right. It is, I think, in recognition at the moment, the process that we're following, it's a number of parallel processes. Usually we would like to have all the checks and balances in place before we launch a new program. We haven't been able to do it that way at the moment. We have done a lot of the lead-in work, consultation with the ministry around the collaborative commissioning project, which is what we had designed for our Connected Care Plus. We've been able to leverage that in being able to scale up these for the home monitoring patients.
Thank you for the detailed outline there. This one, I think, Netty, this might make sense for yourself to answer. It's a bit of a long question, so let me read it out. To Southern New South Wales LHD's virtual care model, were the COVID-19 patients admitted under the care of the virtual respiratory physician and registered as admitted under specialist care, or do they remain under the care of the GPs with the respiratory consultant share care? Where were those patients referred from? ED, GPs, self? Could you please clarify transfer of care processes between the medical care providers of patients who remained under virtual care and did not require hospital level of care? So I think, Netty, I'm sort of reading this very much as a question regarding the care model and how the clinical governance model is working.
Yep, sure. Thanks, Jahan. Long question. I'll try and answer as much of it as I can. So referrals tend to come, especially for COVID-19, through our public health team. It's obviously a condition that we've got to manage from the public health perspective. Our teams work with the GPs to ensure that we have the information that we need in terms of what those patients require. We were fortunate that the patients that we were supporting were on the Lighttouch or the low acuity pathway, and we were able to admit them in a virtual ward through our nurse practitioner with, like I say, with input to the GP. There were some referrals that did come through the GP or through other services. But yeah, same process. We linked in with our GPs at all times. In terms of discharge, was it discharge or was it transfer of? Sorry, Jahan.
I read it as transfer of care processes between the medical care providers of patients who remain under virtual care and require hospital level care. So I think it's between the care settings.
Yeah, so we haven't to date had a patient admitted into an acute facility, but we have some processes in place, and we ensure that we have that medical governance and our respiratory physician to inpatient MO discussions, so that we have got that pathway for acute care if needed. But so far, we haven't needed that.
Thank you, Netty. Shannon, I'm sure this one is something that you'd have a lot of information on as well, so love to hear your opinion on it.
with our COVID patients, we have similar to New South Wales, we've had the different streams of patients. So a moderate touch patient would be admitted under our HIT service, our hospital in the home service, and then a light touch patient, where most of our patients sat within the West Moreton district, and they were admitted under our nurse navigator light touch model, and they were admitted under a virtual care model that sat under our ID specialists. So the clinical governance sat with our ID physicians, and then our nurse practitioners monitored those patients virtually while they were at home. And obviously, similar to New South Wales, our public, it all started with our public health service, and the patients would be tested in our fever clinics that we set up in conjunction with our hospital within West Moreton Health Service. So patients were seen in the fever clinic, identified by public health as positive, and then streamed through to either moderate or light touch virtual care models. And all of those patients have been streamlined through to clearance now, and obviously discharged from the virtual care models and back into the care of their GP.
Thank you, Shannon, for sharing your insight on that. I think we've got time for just one last question. And the question is from an anonymous attendee. It's, how do each of these programs stack up financially? Great question. Do current funding models adequately support them? It's the age-old question. Maybe, Lou, from your perspective, have you got a opinion on how the sort of business models and the return on investment models work for these type of solutions?
We've done some work as part of our Connecting Care Plus, so a commissioning model, and what we can see from the learnings from MeCare from West Moreton is that there is that reduction in costs for inpatient care. I think one of the other savings that we're trying to articulate in Southern New South Wales that's of particular interest to us is the ability to increase our productivity in the community by reducing the travel burden. You know, we're a fairly broadly spread district, and, you know, sort of talking 500 kilometres from end to end. So the ability for us to actually service more patients, get in earlier, preventing that hospital admission, but also increasing the activity output. That's our anticipated benefit. Because we haven't launched that Connecting Care Plus program, we haven't got the real data. But what we're doing is working really closely with Philips and using the learnings that West Moreton have produced for all of us, so that we can hopefully leverage those efficiencies and the financial savings.
Excellent. And Melinda, from your perspective?
Well, if I could run my actual hospital beds for as cheaply as I can run the beds in MeCare, I would be happy days. You know, but the cost of care is not just about dollar cost. You know, we're in this to help support people for a long time at home, because we know that home is where people need to be. So we are playing a much longer game in West Moreton, but it is dollar for dollar. Our virtual care beds are much cheaper, and they have just as good outcomes. So return on investment wise, it is there. You know, and I'm just waiting for funding models from the Commonwealth to catch up, and that might be things like cashed out models or turning to value-based healthcare. And when they start paying for prems and proms, we'll be in the box seat with this program.
Thank you, Melinda, and that's certainly a great way to finish the session up. Franca, Melinda, Netty, Shannon, Lou, thank you so much for your time today. I think I'm 100% confident this has been very insightful to everybody that has been on. And thank you for those that are attending remotely. I hope you've learned something from these innovative health systems. On behalf of Philips, I'd like to thank you all for attending today's session. Have a great evening. Thank you.